Good evening, ladies and gentlemen, colleagues and friends. Welcome to another evening webinar brought to you by SPG. Thank you for joining us this evening, and of course, as always, I want to welcome to the panel my friends and colleagues, Dr. Chou.
Hi everyone.
And Dr. Agnes.
Hello.
This evening, of course, we are going to be sharing with you on the topic of improving implant outcomes. It's all about tips and tricks of how to improve your everyday clinical practice in terms of dental implants. Now, of course, tonight's webinar, as you all know, it's live and interactive, which means that you get to send in all your questions to us. And me also being the moderator, I will be sharing with your questions to the panel to my best abilities so that we can make this into an interactive webinar as much as possible. This webinar will go for approximately an hour and a half. Towards the end, of course, you will be receiving your CPD certificate. Now, what's different to today is I know that you guys are very logged in, but to receive your CPD certificate, please scroll down to the bottom of the screen that you're on to fill in your details for CPD certificate. I will remind everyone of this throughout the webinar. If you have missed our previous webinars, please do, you can check them out on our website, which is www.sitpg.com.au. You go to dentist resources to find all the previous sessions that you might find quite interesting. Tonight's session, of course, is not possible without our sponsor, Credible. As you all know, that they are the specialist in terms of financing, getting loans, and especially these days, the interest rate being so low, getting a loan is next to nothing. It's now a better time than ever to get in contact with Credible, particularly as you all know Sandy and Teresa, who's been in the industry for a long time. I do like to thank the entire team at Credible for their incredible services to us over the years. Our second sponsor for the evening is Experian. They are the experts when it comes to insurances, covering a whole range, whether it's personal insurances like income protection, life, trauma, TPD, etc., and a whole range of business insurances, including for your particular practice or for professional indemnity. Now, what's very different from them is that it's the fact that once you sign up with Experience, taking up any insurances with them, they will assign you a case manager, which means that if you have anything that you need to liaise, you have a claim that you need to contact an insurance company, you do not need to contact the company directly. All you need to do is to contact your case manager, who will look after everything for you. So for poor people in our profession, I think that's a terrific service to have. And for our viewers this evening, they're offering a cashback of up to $500, depending on the policy that you take out. All you have to do is to mention SPG Chatswood from tonight's webinar and to claim that cashback when you contact or email them. For our referring dentist that's joining us, again, on behalf of the entire team at SPG, I just want to say thank you for all your referrals and for your trust in us over the years. It is extremely important to us. We do not take your referrals lightly, because we do understand that often pushing your patients to us is not just one email or one letter. It takes often many sessions of harassment to push your patients to us, and that's why we deeply appreciate your efforts. Thank you. And for the ones that's joining us for the first time this evening, just a little bit about ourselves. Sydney Prosthodontic Group, we're located in Chatswood, offering a full range of restorative as well as implant surgical services. Our mindset at SPG, it's about relationship building. So not only we're here to look after your patients realizing their dental dreams, but also is to help you overcoming your clinical challenges that we all face from day to day. So if you ever have any problems, whether it's with patient treatment or whether it's with any personal issues, here at SPG, you can always feel free to contact us, because with our collected resources on hand, we're here to help you. Over the last 10 years, we have carried out over 200 hours of free CPD, sharing with our referring dentists what we have learned over the years, and tonight is no difference. So that's enough about us. Let's move on to the topic of the night on dental implants. Of course, we all know that dental implants is a mainstream treatment modality these days, and of course we're always seeing a whole range of different problems. Any particular type of problems that you guys see very often in your day-to-day work? Agnes, maybe we'll start off from you.
Yeah, I think in terms of coming to complication, soft tissue complications are one of the common ones, where you may see tissue erythema around the peri-implant soft tissue, and you take your periodontal probing and there could be bleeding on probing, etc. Then you go and take a PA, any related bone loss in the area. So these are common biological problem that we see. What about you, Johnson?
I do see mechanical problems from porcelain chipping to abutment screw loosening, repeated abutment screw loosening to abutment screw fracture.
Yes.
And then in molar cases where I see people put a narrow platform implant, and then the monolithic material, whether it's gold or zirconia, and then where all the loading is onto the implant, and then vertical fracture of the implant or horizontal fracture. We
do get a lot of bruxes in the practice, don't we?
Yeah, a lot.
Well, with dental implant treatment, we all know that we can use implants to replace single missing teeth. With our procedures of risk preservation, a variety of the grafting procedures, we can get very particularly achieving the aesthetic result that we need most of the time. For more comprehensive or more complex cases, this is a case with a terminal dentition. After full clearance, you can place a larger number of implants, and subsequently with fixed prosthesis to provide the patient so-called their third dentition. There are some patients which often may have a downhill dentition from a severe periodontal perspective, and for one reason or another, it could be because of hygiene issues or perhaps of increased risk of peri-implantitis. So some of these cases are perhaps better treated with removable implant overdentures. So this is one case where a couple of implants were placed, and then we splintered the implants using a customized titanium bar, and that's because a number of the implants have to be grafted, and I just personally feel more comfortable with splinting implants in this particular manner, particularly for the maxillary arch, and then which was subsequently retained in an otherwise removable denture. It's slightly different from a conventional full denture because it doesn't have a palate. That's one main difference, but otherwise it's removable on demand. Mandible, 2 implants is very common, and we do find that in our practice sometimes placing 4 implants in the mandible with these locator abutments significantly improves the stability and the retention of a conventional denture, such as this on screen. To provide the patient with the aesthetic good amount of facial lip support, that's one huge benefit I find with these, and of course ease of cleaning and ease of maintenance. Now, one type of treatment modality that's not talked about a lot, I think, in implant dentistry is the ability for strategic implants to help to retain partial dentures. Take this case here, for example, where the patient has lost all dentition in quadrant 2. Now, if you were to make a conventional removable prosthesis, then it's very, very difficult to get that clinical satisfaction, whether it's retention or stability, and of course, furthermore, perhaps aesthetics. So by placing these strategic implants, you can use either 1 or 2. And now that's all the retention that in quadrant 2 will be required in this otherwise conventional partial. Now in quadrant 2, you don't need any clasps or rest seats to not only achieve a good aesthetic appearance, but also make it much more functional. So it's all well and good, But what sort of problems are we seeing? Now, this is one of the perhaps the best studies out there at the moment to look at longevity. This particular study, it's a systematic review, which looked at all the qualified studies that's been published after the year 2000, meaning that they removed the studies before year 2000, which they think that there could be some still learning that's going on in the implant community after year 2000. This is more experienced clinicians that shouldn't be having these beginner type of mistakes. And based on the study, what they were looking at is single implant crowns, outcome of single implant crowns. And what they are finding is that the implant survival rate is looking excellent, and so is the prosthesis survival rate, or above 96%. The aesthetic complication rate is 5.4%. So what falls under the aesthetic umbrella is anything that the patient, could be shade, it could be color, could be incisal edge, etc., etc. Biological complication rate, this is looking at peri-implant mucositis, peri-implantitis. So to my surprise, it's 10%. I thought it would be a little bit higher, but perhaps this is a very experienced group dealing with these sort of issues. But what concerns us the most, particularly in a prosthodontic practice, is the technical or the prosthodontic complication rate, which is ranging anywhere between 16 to up to, good God, 53%. That's half of your cases. So on average, the study was quoting somewhere around 30-something%. So even if we're going to take the lowest denominator of 30-something% of prosthetic complications, plus 10% biological, plus 5% aesthetic, that's still close to 50% of complication rate, which is very, very concerning. And this is based on best available evidence that we currently have. So in a practice like ours, of course, if we have that sort of complication rate, I don't think we'll be doing very much after even just a couple of years in practice. So that's is one of the main reasons that why we wanted to share this particular topic with you guys tonight, is that it is actually very common to see implant-based complications, but more importantly is to recognize the why behind it and what we can do clinically to help to reduce that, not just for us, but for all the ones watching at home, and of course that would benefit our patients at the end of the day. Now let's break down the technical complication rate a little bit further. So the top 4 most common problems with technical complications: number 1, abutment screw loosening; number 2, porcelain fracture or porcelain chipping; number 3, abutment screw fracture; and last but not the least, the fracture of the whole entire implant. So let's look at these one at a time, starting from abutment screw loosening. Again, maybe I'll come to you, Agnes. Is that how often do you see that, and what do you advise? What do you think it's caused by, and what do you advise for our viewers at home to reduce this potential problem?
Okay, I think abutment screw loosening is one of the more common, but also more favorable type of technical complications that we see. Because in theory it's just loosen, you can go in there, you can retighten, you can change to a new screw. The reason why it happens is because the initial torque value that you torque it down to is coming loose. So one of my tips for our colleagues out there is that when you are initially issuing a crown, it is very important to think about passive fit. I know I'm talking about only a single unit, and passive fit is the common term that is more reference to breech work or splintered units. But it is a simple concept to understand when I put it that way, because what you ideally want is that you would like the crown to be sitting on the platform without other resistance, whether it be proximal contact or soft tissue pushing its way up, before you really apply the torque to try and tighten it. Because otherwise, whatever torque value that you give can easily be somewhat loosened over the coming immediate term. Also, if there is no passive fit to begin with, if you're just trying to crank it down, then that is when we have had some helpfulness to our general colleague who have fractured either some of the porcelain on the crown or the screw in the process that we've had to salvage. So those are very, very important key to proceed along the way. And one of the handy tips is no matter the system of implant that you are using, whether it's internal connection or external connection, that passive fit you could feel commonly by hand is whereby as you wind this abutment screw down, it should be smooth and then come to a complete stop. If along the way as you're tightening this screw, it already feels like there's a little bit of pressure to sort of gouge it or get it into place, then that is often an indicator that your crown is not exactly fitting onto the implant platform. And you should therefore just double check before you force forward. And I mean, one of the most common areas in this scenario will be proximal contact or any crestal bone if this particular implant platform is placed a little bit deeper.
Absolutely.
Yeah.
And what about in the instances where there's repeated abutment screw fractures, abutment screw loosening? What is that perhaps telling us, and what should we do about that?
Yeah, so in incidences that is not in this initial phase, commonly the indicators would be that there could be a certain parafunctional risk. Or high load contact that has not been screened. And it really warrants to have a more in-depth conversation with our patient at that time. Certainly when it first happens, it's a much better time to talk about awareness of any parafunction or real consideration into or compliance of using a splint, etc. Because I think these mechanical issues, in a way, of course, we term it complication, but screw loosening, I feel, across all the different types of mechanical complication, it is a realistic one to need to surface throughout the lifetime of the implant. Because it is just a mechanical connection that is being worked on. It is a biological system, but these mechanics are there. And if you were to function on any joinery or chair or cars, etc., people don't expect a screw to maintain its connection lifelong. Certainly when it's not, especially when it's used every day. So the more it's being put on load, the more common wear and tear there should be expected. And I think this on the areas of different complications, probably one of the easy one to communicate across, and you certainly would talk that earlier. No, that's very helpful. And now on the second most common mechanical based problems is porcelain fracture or porcelain chipping. We certainly see that a lot in a pros practice. Johnson, what's your view on this? And also similar sort of questions. How do you normally deal with that? And what preventative sort of strategies could you offer?
Usually the cause of porcelain chipping is usually due to parafunction and also the framework design. So parafunction, there's not only nocturnal parafunction, but it's also daytime parafunction as well. I had a patient who was an electrician, and he said to me after he's chipping his porcelain for the second time, he'd tell me when he uses his hammer drill, he just clenches his teeth so hard that while we provided a 10 micron shim stop clearance is not enough because he clenched so hard.
We'll have to go for 100 micron next time.
Pretty much. So I think I think it's important for them to know porcelain, which is fused quite well to the framework underneath, doesn't just chip easily. So there's usually some parafunction, so it's important for them to know and to control that. Secondly will be the framework design, whether it's a porcelain fused to metal or porcelain fused to zirconia. Usually they do wax up design and then they cut it back. For the zirconia, they would do double scan. They scan the wax up and then they design cut back digitally for that. And also in terms of in some areas where there is the implant screw coming out, where the porcelain thin is very important to be reinforced, whether with metal or monolithic zirconia material to reduce porcelain chipping in those thin areas.
Yeah, it is really important for that feldspathic porcelain not to exceed, say, beyond 1 or 1.5 millimeters, isn't it? Because it doesn't, I mean, feldspathic porcelain is one of those ceramics that it doesn't mean that the thicker it is, the stronger it gets. Right? So it's like a piece of glass. It doesn't matter how big the piece of glass is. If you tap on any corner with a little hammer, sooner or later that's going to be a little chip on that corner of the glass. So,
agree.
So framework design, absolutely. Our next third common mechanical-based complication is some sort of fracture. Either on the left-hand side of the screen, we're seeing this abutment screw fracture. Using different tools, we can actually unwind it most of the times. And then on the right hand, it's a bit more catastrophic. It's a fracture of the implant of some sort. Then often there's no rescue with that. In terms of the abutment screw fracture, like what Agnes was saying earlier, is that it's fairly common. It's particularly in a specialist practice. For our viewers tonight, if you think that's not very common, what you saw on screen is pretty much just under 6 months of amount of work that goes into a specialist practice. We don't enjoy that often. But it is something that we do have to manage. Usually, when you look at the history of these things, the patient usually says, yes, this isn't the first time that something comes loose. It's probably the second or the third time. Previously, the dentist, yes, of course, just tightened it down, and then for this time, the whole crown, the whole thing just came off. So to me, whenever there is an abutment screw loosening issue, to me that's a warning sign. Particularly late stage abutment screw loosening. I find if it's early stage, say a week or two after the issue, that could be the problem that you alluded to earlier, Agnes, which is could be the interdental contact was too tight, and therefore when you try to tighten it down, it's the interdental contact that's somewhat holding the crown up. So yes, you delivered the right amount of torque, but that amount of torque did not necessarily put into the preload of the abutment screw. And that's why as the neighboring teeth moved, then subsequently the screw loosens. Of course, that will make sense, and hence why you get early abutment screw loosening. But assuming that if it was, say, quite a number of months or even say a year or two later, and that's when the abutment screw came loose, I think most likely it's some sort of a loading issue, whether it's part of occlusion or whether it's parafunction, but it's definitely some sort of overloading perhaps of that mechanical system, and that's why it's a warning bell telling us that, hey, something is not quite right, pay some attention to me. And if we turn a blind eye and go, oh yeah, that was an easy thing to fix, let me just crank it down a bit more, well, things may just fracture.
Yes.
We don't always able to take out a broken abutment screws. Maybe one a year that I failed to do that, but most times we are able to. That's the good news. And now on to our next type of complication, which is biological type complication. So we're talking about anything involving could be peri-implant mucositis or peri-implantitis. This is an inherited case. Implant was placed by another surgeon in 2008. 5 years later, that's when I first saw the patient. You can see on the right-hand side of the screen that there is just generalized horizontal bone loss affecting particularly the distal implants. Some viewers may feel that, well, this is an external HECT implants. They are not as good as internally connected implants. Well, at least from our point of view, we feel that every implant or any connection or system tends to have that sort of problem. And some viewers may say, well, this is a bone leveled implant, whereas there are some systems out there which is a tissue leveled implants. This is a case that was placed by a very good periodontist, excellent clinical work, and they've used, of course, a tissue-leveled implants, which, of course, there's no micro gap in between that junction. But again, this is a standard placement, but yet there's still significant bone loss. This is 3 months after placement. So not a happy day. So I guess the take-home message is that peri-implantitis can occur in any patient, sometimes using any particular system. It doesn't matter your level of clinical expertise, it can happen to just about anyone and everyone. So Johnson, what are some of the ways that perhaps we can reduce this incidence from happening?
I mean, of course, it's important for the periodontal disease to be treated and stabilized, and then they exhibit very excellent oral hygiene before they start the treatment. Quit smoking, should they have a smoking habit. But I think it's very important to let them know, even with or attending all these changes, they are still in the high risk group with what we call genetic predisposition, in which it was the case here. Periodontitis was controlled, stabilized, excellent oral hygiene, placed by a periodontist, and yet this still happened. But he was informed that this could potentially happen because of increased risk. So he's come to acceptance. I think it's important to let the patient know. But what we have noticed anecdotally is, we tend to do this as a two-stage procedure, as opposed to one stage. And then, would you explain why two stage is better than one stage? So
this is very much anecdotally, but we felt that in this particular group of patients who has suffered periodontitis or sometimes severe periodontitis, we could consider this group because it's more at high risk. So therefore, perhaps we should change our protocols a little bit from conventional protocol, which is just say antibiotic prophylaxis. In this particular group, I think we've now introduced 2 weeks of chlorhexidine mouthwash. This is of course assuming that their periodontal condition is already under control. So there is no active periodontitis. They have good oral hygiene. They're not smoking. This is under that pretense. Furthermore to that, we're sending the patient a reminder. They start a 2-week daily chlorhexidine mouth rinse, and on top of that, all implant surgeries are done under two-stage approach. Because we've just seen a few cases now that standard implant surgery, but 3 months to come back, you take a PA, good God, there's this 3 millimeters of bone loss. And there's when you're probing, there's no bleeding or probing, there's no separation probing, but yet the bone is just melting away. You scratch into your head, what's going on? So we found that using a two-stage approach, just completely covering it, for some reason, things just looks better when you uncover that. Now, whether this is going to hold still to be good in the long term, we don't know.
No, we don't. True.
Well, we can say that we're trying our best. And coming now to the third level, the last type of complication in the group, being aesthetic. As we all know that an implant is a enclosed object, and the younger the patient that you place these implants, because of whether you call it a maxillary growth or modification, your neighboring teeth, bone, and soft tissue will migrate downwards coronally, and that's leaving the implant behind. Now, what's very unique about this particular case on screen is that this is not a young patient by any means. The patient received this implant treatment to replace the single tooth number 2-1. It was 43 years old when he has that implant placed, and this PA and the previous photograph you saw was taken 18 years later when the patient was already in their 60s, and that was how much still continued maxillary modification that's occurred. So it's rare for patients of that age, but obviously much more likely for patients of a younger age. Agnes, any particular advice on how young or how old should a patient be before we embark on this sort of treatment to minimize that sort of problem?
I think, personally, I would still await the pubertal growth to complete prior to placement of an anterior implant, especially in high aesthetic area. And by that, I mean, for males, sometimes I would not hesitate to wait until they are 22, 23. and for females, sometimes well beyond 21. Having said that, you know, for a young individual who have lost their front tooth, it can be emotionally and socially and sometimes mentally exhausting for the individual. And the eventual modality of choice, of course, have to balance with these aspects. So even though I do say that it is not by default that we would place an implant for earlier, of course, sometimes the whole management have to consider the picture in context. And in those particular special cases where we consider otherwise, and sometimes it's not just implant, it could be other form of fixed tooth-borne replacement. We just have to communicate the potential need for another revisit of these at a certain stages, so that they know what is actually planned ahead of them.
And I guess that's even more important why perhaps a screw retained restoration is just going to make everyone's life so much easier, isn't it, down the track when you need to resurface these implants, whether it's the porcelain that's chipped or whether it's aesthetically you need to modify that. Of course, we're going to talk about implant design in just a moment. As you know, ladies and gentlemen, tonight's session is live and interactive, so do send in your questions and I'll do my very best to pass the questions onto the panel. And also to receive just a reminder to receive your CPD certificate for this evening, please do scroll down at the bottom of the screen and enter your details there. Here we have a question from the audience. What's the minimum torque you would need to put a healing abutment rather than complete burial of the implant? Well, we can start with maybe with this first part, torque of a healing abutment. I have seen certain surgeons sometimes to test out whether a implant is osseointegrated or not. They would tighten the healing abutment down to whether it's 35 or somewhere around there Newton centimeters. And if the patient doesn't say ouch, then they will say yes, the implant is osseointegrated. Yeah. That is one test which I do not recommend, and I repeat, I do not recommend, but I know there's some surgeons that do that, and the reason why I do not recommend it is because for most implant systems that I'm aware of, the healing abutments are not meant to be tightened to 35 Newton centimeters. It's probably not even 15 Newton centimeters. It usually is finger strength only, and you know, that's probably around 10 or 15 or something like that. Because the couple of cases that I saw that has happened is when they start to torque down the healing abutment, particularly when you talk about a narrow platform healing abutment, when you torque that down to about 35, the little screw thread bit that actually breaks off and it gets stuck inside the implant. And that sometimes really, there's a lot of binding involved. And sometimes you can't get those out. And if you can't get that out, then that's a buggered implant, which you need to find out a perfectly good implant, and that's not a happy day. Moving on from aesthetic. This is from one of my earlier days in my career. This is a posterior implant crown that I placed and restored. This is an upper 24. When the case was finished, I thought I did a pretty good job until I set the patient up and gave her a mirror, and my heart just sank. Back then, in my younger days, I did not have the guts to tell the patient what to look for. But you know, these days, to me, what is aesthetically important is not just necessarily that central incisor right up in the front. Any posterior aspects, when the patient particularly have a high smile line, that buccal corridor is showing, all that is also just as important. And that's why for all our posterior cases, especially the ones with high smile line, we now pay particularly attention to the soft tissue volume, because that is the key to make it look good. It's so much easy, working with great ceramics, it's really easy now to make a tooth look good, but how to make that pink look good, it's can be a lot more challenging. So do pay particular attention to that. Let's now get on to a slightly change of topic or change of pace. We're looking at treatment planning, because we often see a large number of cases that gets planned or the implant gets inserted. Sometimes may not be in the best amount of space. So that's one topic we want to talk about, is how much space do you need? In the particular these x-rays, you can see sometimes the space could be a little bit too tight or too little, and that's the PA on the left, or sometimes the space maybe feel a little bit too large, that's the PA on the right, where you got 2 missing premolars. The space is somewhat too large for 1 premolar and yet too small for 2 regular sized premolars. So what do you do when the space is not right? Then of course ideally, if the patient allows for it, you go through for some sort of orthodontic treatment first to move the teeth, so to give you the perfect amount of space. Then you place the implants in the ideal manner, in the ideal positions, restore them, and everyone has a happy day. Now, how much space do we need, Johnson, from a lateral perspective?
Yeah, according to the literature, if you use the smaller implant that's available, this is excluding mini implant, of course, it's a 3 millimeter, but you still need 1.5 millimeters on either side to have to preserve your papilla. So the minimum is 6 millimeters. That will give you a smaller than average lateral incisor.
And that's just for lateral incisors. And
yes.
of course, if we're talking about a central or something a little bigger, you need only bigger spaces.
Bigger spaces, yes.
Yeah. And in terms of this, so this is assuming we're talking about a small tooth, so like a lateral incisor or something like that. And this 6 millimeter space that we're talking about, is that between the crowns, is it intercoronally?
Yes.
Is that at the crestal level, or is that at the apical level that this measurement is referring to?
I mean, from a coronal perspective, I mean, it's important to get that dimension, the ideal, to make you a nice shape or the nice width tooth for the aesthetics. But from implant perspective, it's very important to have that 6 millimeter or minimum crestally and apically.
Absolutely.
Because especially when we work with orthodontists, we ask them not to debend until we've seen a flat film x-ray to ensure we have that minimum 6 millimeter crestally and apically. Yeah.
Yes. Yeah, absolutely. Here is a case that we dealt a little bit earlier. It's a young lady with a congenitally missing upper canine. And so pretty much most of her adult life she's been wearing a removable partial denture. We can see the space is very small for a canine, of course. So she had the world's smallest little canine that I've seen. And to my surprise, she said, I'm very used to that. I don't want orthodontics to open up that space. So if you can give me some sort of fixed implant in there to give me a fixed canine, so I no longer have to wear this little partial, I will be delighted. So I was very skeptical at first, because how could you be happy with such a small little canine? But anyway, so I proceeded with with an initial assessment. So this is just taking a PA, and that white flat dot, that's a known radiopaque marker. So essentially, it's a part of a paper clip that I cut down, and using digital calipers, I measured that to be 5 millimeters. You can then stick that. You can autoclave it. You can stick that to your film using sticky tape. So that, using, of course, digital radiography, you can then calculate exactly what's the amount of space. So you guys can see that the intercoronal distance is only 4.4 millimeters, which is very, very narrow. But the intercrestal level, which is in yellow, that's 6.5. So that satisfies your Johnson, that 6 magic 6 millimeter number you were talking about.
Yes.
And of course, the interapical distance is even better than that. So it's 8.3 millimeters. So from a surgical standpoint, this satisfies, at least from a lateral perspective, the enough space available. The rest is aesthetics. How large do you, or how small do we want that canine to look? So this was the implant placement, and this was the final result. Again, it's a small canine, which there isn't perfect, obviously, symmetry between the left and right, but for this particular patient, she was very happy with it.
It's what she used to, isn't it?
It is. It's better than what she's used to. I did actually carry out about 0.5 millimeter artificial odontoplasty on either side, so I turned it into roughly a 5 something millimeter. Still a very, very small tooth, but biologically it was safe to place that implant, and to me that was one of the most important things.
An improvement for the patient in terms of function, and a little bit bigger than before.
That's right.
Yeah.
Well, we got some questions. Agnes, there's an aesthetic question, which is talking about previously when that implant becomes infra-occluded. How do you correct the soft tissue then in those cases when the implant is now shorter?
Okay, so it depends on the discrepancy of the infra-occlusion or the change in zenith, of course. Sometimes you try to do more minimal intervention as possible. In a younger patient, often with a high smile line and that there is a bit more gum showing, often as they continue to grow and their natural dentition is even more gummy, then you have the opportunity to revisit the aesthetic reorganization at a later stage. And that is why I said before that with earlier placement, sometimes to deliver a desirable outcome at the end when they finish their growth, it's not without expenses or further commitment to more work down the track. But of course, assuming that you had communicated the potential of all these, then one of the ways to manage this is to balance the zenith with other dental restorations, whether it's through means of orthodontics or involvement of periodontal surgery, veneers, etc., etc.
Great, thank you. Another question is asking, assuming that we're replacing, in the case that we spoke of just then, with this canine that is being replaced with a single tooth implant. Now, I know what I did there, but what type of occlusion would you give that particular implant crown, Johnson?
In the canine where it's subject to very high loading, it's never a canine guidance.
Yeah.
Always exclusion from any guidance, and there needs to be a shim stock clearance. Yeah,
this is something that we all had to learn sometimes from the hard way. Is that although canine guidance from some occlusal school of thought may be a desirable outcome, but it's never a good idea when it comes to implants, single tooth implants on a canine. So there's a large number of cases that we had to replace canines over the years. We used a single, that's just for one canine, whereas canine may have canine guidance, the natural canine on the other side. But for the implant, the canine that we're replacing cannot have canine guidance, which means that clinically that incisal edge is actually shorter than your other side. So that's something that we actually do warn the patient up front, which means that sometimes we may have to carry out some odontoplasty on the canine on the other side just to balance the aesthetics at the end, or the patient just have to accept that there's a slight asymmetry between the left and right canine. There's a surgical question on assuming that if you have mild peri-implantitis, how do you then raise the flap and able to clean it well and without achieving dehiscence? I think it's the easiest way to answer is using a papilla sparing incision. So when you're raising that buccal flap, you're not involving the papilla. But with any flap that you raise, there's always risk of having some sort of gingival recession. So do be careful with that. There's another question on what are our views on ceramic implants? Assuming that your implant is made out of zirconia and you place it, how would your restoration design on the ceramic implant be any different to a restoration on a conventional titanium implants? Now, I'm not sure what particular brand of ceramic implant this is referring to, because I know some ceramic implants, they come with their own abutment. So which means the only type of crown that you can have on top, it's a cement crown. Then I'm not a big fan of cement on crowns, but I guess if that's what the system is about, then there is no other choice. My experiences are very limited when it comes to ceramic implants, and yet you can have a screw retained restoration. On any particular thoughts, any experiences on that?
No, my experience on ceramic implants is very limited too. Yeah.
Yeah. So our apologies that we don't have too much insight on that. Carry on with our topic at hand, talking about amount of space. So sometimes you come across one of these sort of cases where here we can see that we have just about 5 millimeters of intercrestal amount of space. You feel that it's just enough to squeeze in a 3 millimeter implant, right? I mean, I got I'm the world's best surgeon. If I can do my thing perfectly, then I got 1 millimeter space inside. I can definitely put it in. Any particular concerns with carrying out surgery in cases like this, Agnes?
I think you really have to consider the periodontal ligament space and the biologic safety zone for your neighboring teeth, dentitions. I have seen some wonders of implant placement that fit into that space and have not jeopardized the actual anatomical roots of these teeth. But like in the next PA that you will see, is that it really encroaches to that PDL space. And and in this situation, even though sometimes initially after the restoration is placed, the whole architecture and form seem to be stable, and you pray so much so that there is not going to be ever any soft tissue issue around it. But most often than not, you will see the subsequent PA also post placement of the prosthetics is that there will be soft tissue issues, which will then have quite a catastrophic outcome to the tooth next door. Yes.
And here we see that the bone there is bone shrinkage from the immediate post-op PA to the post-pros PA, where it's hard to know whether it's mesial or this. I believe it's the mesial aspect of the implant. The surface where the implant is closer to the tooth. In the immediate post-placement PA, you can see the bone appears to be still present, but however, after the immediate post crown insertion PA, that you can see that there's significant bone resorption. Yes. And of course, this is a case that I just found on DPR that attracted a lot of likes, and I thought, well, in terms of surgery, yes, they did manage to squeeze the implant in there, but it's not without consequence. Sometimes implants do fracture, and I don't mean during placement. I mean in the long term, it could be parafunction, could be motor vehicle accident, could be a lot of different reasons why sometimes you may need to remove the implant via trephine. And in cases like this, when it's so close to the tooth next door, you just cannot apply the trephine drawer anymore, because if you did, then that's root planing of the tooth next door. You might as well just extract the central while you're at it. Or of course, any periodontal problems that you have, you automatically would involve the tooth next door. So that's also not a happy day. We have a question that's got to do with the healing abutments. So it's saying, what's the best way to remove a healing abutment if by chance the driver is unable to engage the healing abutment? I assume what that means is the healing abutment is stripped and now they cannot take it out anymore. Any particular thoughts on that?
Yeah, then best way would be to create a slot.
Yeah.
And then get a slot and then just use a torque wrench just to engage it to undo it.
Yeah, so what Johnson's talked about is you use a burr and you cut a slot in your healing abutment, quite a deep slot, and then you use a slotted driver put into your torque wrench to engage that slot to loosen it up. It's not, of course, sounds easy, but particularly for the posterior, sometimes it is a bit hard to do. So the best way to do it is not to get there in the first place. And how not to get in the first place is before you put your driver in the healing abutment, get like a sharp explorer probe of some sort. You poke it in there because often there are food debris that's inside. So loosen it up, use a triplex, air and water, and flush it out first so that there's no food debris inside that thing. Occasionally in the lower anterior mandible, there can even be calculus buildup. I've even seen that. So just use your ultrasonic, you just one gentle tap right in the middle of it, you just go poof, and all the tartar falls off before you engage it. So it's always about prevention. And if you are reusing the healing abutments, then of course check it. So if you strip it once or twice already, check it. Just don't risk it again. Johnson, this question you might be able to answer. Where there's a lack of space, what is the experience with minimal prep resin bonded bridge as per Clausen?
As per Clausen, it's basically they create grooves in there to improve the retention and resistance form. So that is what I consider a more long-term option for Maryland bridges. But often we deal with patients that is growing that doesn't want the teeth to be prepped. So any unprepped bridge where there is a fiber reinforced with composite on top or zirconia, they tend to be a more short to medium term compared to something that is prepped.
So for the viewers out there, I think what this question is referring to is really we talk about PFM types of Maryland bridges, and the preparation involves the adjacent teeth using one or two neighboring teeth, and they make a slot usually in roughly a 45 degree angle to the long axis of the tooth coming from the cingulum, from the palatal, so that your path of insertion of your Maryland bridge is at usually a 45 degree angle to the incisal edge or the occlusal plane. Therefore, that helps to resist the debonding nature of what a Maryland bridge usually would. I've seen some excellent work done.
And I think it's important for our viewers to know that today's topic is on the troubleshoot or how to improve implant outcomes. Certainly we've had previous seminars also on treatment planning and going through the different options. So of course, yes, in each of these case scenario, there would be many different options that would be available. We're not advocating, so with prior discussed about early placement of implant in a younger individual, but then how do we deal with certain complications? And I reiterate again, we're not promoting that we can do this and we do it by default. And again, here we're not saying minimum space, we can still do this, let's go every case by default doing this. No, we're not saying that. We are presenting all the different scenarios of what are the outcomes that we commonly see related to such, so that our viewers out there tonight can have a better understanding of certain plannings that are involved. And if you were to commit to working in these difficult sites, with some of the risk factors that we proposed here tonight, you would be able to consider how to manage the complications thereafter. So,
It's all about prevention. Yes, it's not about complication creation. Now, we have spoken about how much space we need laterally, and now let's go vertically, because so often, we do get referred to cases where this is, Ben, there's a couple of missing teeth. Can you please help in replacing some missing teeth? And often there is already some of a collapse, though, occlusion. There is a decrease in that interarch space. So how much vertical space do we need?
According to the literature, we need a space of 3 millimeter between the head of the implant and also the CEJ to create a profile. But in terms of the vertical space, the recommended vertical space for a screw retained implant crown is 5 millimeters. That does not mean it will be hygienic or does it have a nice emergence profile. It's just the minimum space to fit a screw retained tooth. And that is provided that the patient does not want to have increasing OVD or adjusting of the opposing dentition. Yeah, and I believe you have a case to share with us.
So I guess what you're saying in terms of the space that we need, Johnson, is that from the gum to the opposing tooth, the absolute minimum is 5 millimeters.
Yeah, absolute.
And this does not mean that you can get a nice crown on it. It just means how much space mechanically do you need to fit in, say, the abutment screw, your metal, your porcelain, your da-da-da-da, right?
Correct, yes.
And then, of course, furthermore to that, you need 3 millimeters of space from the gum to the bone above.
Yes.
So the absolute minimum from the bone to the tooth underneath is, of course, just somewhere around 8 millimeters. And that doesn't give you necessarily enough vertical space to create that ideal emergence profile.
Of course not.
In particular for molars, which you need much more. Sometimes you have vertical space to establish that. So this particular case here that I have is it's an implant that's been placed by a surgeon. And subsequently, the surgeon has referred this case to me to restore. So this is the PA that I got with a referral letter, which is please restore. So when you look at it, it looks reasonable. The implant is in a reasonably good position. You think to yourself, oh well, that's a slam dunk. Sure, it's an upper 7. In terms of location, it may be a little bit difficult, tricky to take the impression and issue it, but otherwise that can't be too hard. And this is the post-pros PA. Now, if I'm not going to explain why it looked like that, all the viewers at home will think that Ben's forgotten to take his medication that morning. Why did he made a mushroom for this poor patient? The patient paid for a crown, not a mushroom. So this is the intraoral photo of that particular crown. So what has happened here is that in addition to that, to opposing tooth, which is the 47 over eruption, which has already reduced the interarch space, but furthermore, there's chronic cheek biting. So I had no choice but to remove that more buccal porcelain and even some of the occlusal metal to alleviate for that. So, with 20/20 vision and hindsight, you should say, well, is there even much functional value to that? But, often at a specialist practice, that's when you've been giving lemons, you make lemonade, and the patient has spent the money with the view that there's going to be a crown on it. Well, there's nothing much that I can do but to give them the crown to my best ability. It has some function value to it, but from a hygiene perspective, that's not very good because there is a significant ridge lap. If you look at the PA on the lower right side, in terms of the mesial aspect, the patient really have to floss hard and thorough under that using super floss probably to improve on that hygiene as much as possible. This is another case. This is from a different surgeon. The implant is placed. Again, they came with a referral letter that says, please restore. This case came from the country. So the patient's here for a week. It was immediate extraction, immediate placement. And it's my job to provide the patient with a provisional and then later on with a definitive. So this is what I saw on the day that the patient walked in. Obviously, it's a severe class 2 div 1 type of situation without much interarch space. Ultimately, sure, we're able to restore that tooth with a acceptable looking crown, but I wish that I could have done more beforehand to increase the vertical dimension, the occlusion, because now still with a severe class 2 div 1, although it looks good, but when the patient go into protrusive movements, mandibular speaking, well, there still could be a lot of pressure that the patient puts onto that implant crown, so thus further increasing the mechanical or even based type of complications that we spoke of. And now let's have a look at spacing in terms of buccal-palatal position. For a lot of the surgeons out there, it is important to know that you need the very, very, very least 1 millimeter of space between your implant to the buccal-palatal wall, and many of the studies are actually recommending anywhere between 1.5 to 2 millimeters being the ideal, particularly for the thin gingival bile type, and this is what's going to give you that stability in the long term. There are a lot of immediate work done these days, because our patient is after that instant function, instant aesthetics. This is one of those cases that's been referred to us because unfortunately the implant is placed somewhat more buccal than ideal, and after the placement there has been quite a significant amount of buccal bone and soft tissue recession, resulting in revealment of the implant surface. And once you're there, unfortunately, there's not too much one can do about that. So if you're not too used to immediate placement, I think using some sort of surgical guide is a good idea. So you pre-plan it with that in mind too, so that the position could be more ideally placed. One question from the audience is should you place implant prosthesis in light occlusion or no occlusion? I think we are definitely going to get onto that, isn't it? A little bit later on. There's another question asking about the paperclip method that we were talking about earlier in terms of taking radiographs. So what that is about is you can cut up pieces of metal. I don't know why I cut them in 5 millimeters before, but if I were to do it again, I would definitely cut them into 6 millimeters. And you measure it precisely I was using digital calipers to be 6.00 millimeters. And then what I did was I autoclave those stainless steel metal. And then when you're taking a PA, you get a piece of sticky tape and you put that 6 millimeter radio opaque marker on the sticky tape, and you tape it secured fully down onto the PA film that you're using. And then when you take a PA, of course, now you have that 6 millimeter radio opaque marker using your digital calibration softwares in your digital radiology softwares. You can then, of course, enter the length of your radio opaque marker being 6 millimeters, and then you can measure whatever other things you have on that PA to give you the distance that you're trying to measure. Let's move on to a slightly different topic. Assuming that the implant is placed, it's been properly planned, it's now osseointegrated, and you are ready to take an impression. Do you need to take a PA?
Yes, I do take a PA to confirm my coping is seated correctly. And I think no matter how much experience we have, I still do it, and I will still do it because I just cannot afford the possibility of the impression coping having any error in the transition process. Yes, I trust my feel, and most of the time when I take this PA is fully seated. But even in experienced hands, sometimes when you go in and take that PA, you may notice that there is a slither of gap that you have to try and reseat it again. Whether this could be just a little bit of soft tissue that or a crystal bone that makes you feel like it's fully seated, but it hasn't been. I would definitely take that PA to confirm the seating of impression coping.
And what are you looking for on that PA, Agnes? And what's consists of a good quality or diagnostic PA?
Yes, this is very important. Thank you, Ben. Because when you take this PA, it must be of a parallel film technique, so that along the axis of this implant, not to the tooth. And often it is quite easy to orientate this, because if you're doing a fixture level impression, that long guide pin will tell you exactly how to parallel your film. And it is important of such so that the quality of the PA, you should be able to see the sharpness of the implant threads. Because unless you are taking with precision to that, you may then be able to pick up any marginal discrepancy of the seating of the coping. If there is slightly any angulation or yaw changes, to this PA, you will not see the sharpness in the film. And just like these PAs that you see, even if there is to be a micro gap, it will appear as though it's perfect. And so these are not diagnostic of what you're after. So that is very important. Yes.
Absolutely, particularly for multi-unit cases, isn't it? I mean, if you've got 3 or 4 implants in there and one of them is not right, then that bridge is not going to fit.
No, and I think this is one of the easiest verification process along the different checkpoints, and one not to be missed. Yes.
Absolutely. And in terms of once you have taken your PA and you know that you're home, in terms of the impressions that we use to take these impressions, Johnson, what are some of the material or the technique that you would recommend?
Yeah. So different to the traditional crown and bridge where we need to stretch the gum, get the light body in there. Some people believe in blowing the light body. Some people believe not blowing the light body. For the implant impression, it's a little bit different because the margin is captured by the implant impression coping. So we don't need the detail to go, the impression material to go substantially. But what we want is for the implant impression material to be very rigid. So the problem with a light and heavy body is when the space is quite small, when there's just a limited amount of impression coping of impression material going in there, the replica sometimes moves a little bit, and that is certainly the case even without pouring the die stone on top. And your technician can pour the die stone very quickly, and typically they put it upside, and all the weight of the die stone is on that impression coping and the replica, so that creates some sources of error for that to move. So what we do in the practice and what we recommend is a putty heavy body combination. So what we do is we connect the impression coping, we dry the area, we put the heavy body on top of the impression coping, and also we can load up the putty in the meantime, and we also load heavy body on the tray as well, and then we do our impression. So the advantage of this is when we do it as an open tray technique, we have to wipe off the excess. So wiping off excess from the putty material is quite easy, like Play-Doh. And sometimes, when I used to use it with heavy body, it's difficult. Sometimes you take too much off and you have to add some back. And with the light body, sometimes if you don't sit the patient more 45 degrees, the light body flows back. So, and some people may say, well, you're not capturing the soft tissue well, but all the PVS have that flow under pressure effect, so you get a very good image or capture of the soft tissue.
I completely agree with you, which is in the past I also use the impression material similar to when we're doing crown and bridge work, which is you put light body around your implant because you want the best level of soft tissue.
Yes.
Like you're doing a crown, and then you're doing your real regular, your heavy body. And the problem with that is, especially in some cases, it could be the narrow platforms, or some cases where your implant is placed quite deep. So your resulting implant, after when you're taking that impression, you put in your implant replica, and you can feel that the thing is actually very easy to move.
And last distal like 7.
Sure. So with that, we've found in the clinic that once you have that model poured up, you've got a crown made, and you try in the mouth, sometimes it just doesn't fit that well interdentally in the context.
Agree.
So we've learned over the years that your implant impression needs to be rigid, and rigidity sometimes it's even more of an important factor than soft tissue absolute ounce of detail that there is. So that's why we have our protocol is, well, what is the combination of the most rigid material that you can find on the market? So it's heavy body PVS and impression putty. That gives you the most amount of rigidity, and the putty pushes that heavy body into the soft tissue a bit more. So because of that sexotropy on these PVS materials, the ability to flow under pressure, therefore you get that much better in detail.
I think certainly you don't get those paper thin, high detail, but we don't need that around a single tooth implant restoration. And most of the time, the heavy body is enough to capture the zenith contour, I would, in particular, aside from putting the heavy body around the implant prior to sealing the putty, I would also apply this heavy body with the gun along the gingival zenith of the neighboring teeth, or especially the contralateral teeth that you would like the detail to be at least captured for your ceramist to provide any form of symmetry. So there are some thought process into it. And the other heads up in doing this technique, which I also agree with Ben and Johnson, it is a very good technique. I value that rigidity over the high detail, is that when you go in and do your MMR as well, so your MMR material will typically actually flow even more than your impression. So it is very mindful to take note, either trim this MMR afterwards yourself or let your laboratory ceramist know, so that they are aware the thin slither of detail from the MMR is not actually going to be able to position to the model. You actually got to get those details off and just have the gross seating of the MMR to ensure it fits well. So those are the other aspect that goes into with this technique, but I certainly would value that rigidity and the accuracy of my impression for this purpose. Yes.
Terrific. Question from the audience: what type of tray would you use? Quad tray, or full tray?
Yeah, so we do use full tray. I would not need often no need for any custom tray for smaller units of cases, especially with the putty. That takes care of the form, basically. So just your stock tray, open tray. Yeah.
And would you consider using polyether Improgum as opposed to PVS?
Polyether itself is quite highly accurate, but the problem is it's not the rigidity, but it flows so well into all the undercuts. And we treat a large number of elderly patients, like people in their 60s, 70s who have pre-existing crowns. Even using a putty heavy combination, you have to work. Well, when we take it out, it feels like pulling the teeth, and with polyether, it's only going to be more. So I don't use polyether because often it's more difficult to remove.
I think the material itself is an excellent material. It's quite hydrophilic compared to a lot of PVS.
Yes.
It's also has excellent rigidity. Theoretically, the material in itself is an excellent material. There's nothing wrong with that.
Yes.
It's just the handling and particularly when you try to take it out. That's when sometimes
I think in terms of the rigidity, it's comparable to PVS when you're working in a combination of putty and heavy body. So we're not talking about heavy and light body. But in terms of stiffness, polyether is more stiff and will lock into those undercut more. I think in the end of the day, though, both material as an operator handling, you do have to block out any undercuts or potential trap of this material. So for both, technically, you will have to do that. But in terms of a patient's sense of comfort and less of that pulling effect, there is that benefit in using the putty and the heavy body PVS. But I'd be happy with both. The other factor to consider is if you're using polyether, then the laboratory have only within 2 days to pour up that model for you, because the polyether, the accuracy stability is only 48 hours versus PVS, which is considerably a bit longer.
Thank you, Agnes, and thank you so much for the audience at home sending your questions. Keep them coming. And I will do my very best to direct your questions to the panel. And once again, to remind our viewers tonight, to receive your CPD certificate, please scroll down to the bottom of the screen to fill out your details. This is a question that I had never actually thought about, but I think it's a great question. Is there a minimum gap you like between the impression coping and the adjacent teeth, especially where the implant is not placed in the same long axis? So is there... how sometimes when, say, especially for narrow platform implants, your space is so narrow, and by the time you put in your impression coping, there's often practically no space
Yeah.
between your impression coping and the teeth next door. And sometimes there are surgical challenges. For example, you're on top of a very narrow space that you have to work with. The two teeth root next door is not absolutely straight, right? Your central incisor often may have a little bit of a distal, root tip.
Yep, yep.
So yeah, you've got 6 millimeters here to place your implant, but your implant actually has to be slightly off that paralleled
Yep.
coronal level.
Yep.
Because you don't want to prank the apex of the tooth next door. So you have no choice that your implant is slightly on an angle, therefore
Yeah.
impression coping
Yeah.
is coming on a slight angle. Therefore, on one side, you are literally touching,
Yeah.
scraping the side of the teeth. So
Yeah.
I guess here the question is there a minimum gap that we need to consider?
I don't think there's actually any available studies on this, but it is a manual handling type of question, and I think it's a very sensible one. So commonly I would like to have at least 1 to 2 millimeter free from any adjacent tooth, purely because even on the seating of this impression coping, I absolutely do not want it to be touching the next door tooth. Again, if you are touching any other hard surfaces, I would also doubt the actual seating, whether it's sitting passively. What I generally do if I encounter such a case and I still wish to have, and my default is a open tray fixture level impression, I would customize, adjust my impression coping so that it is not so close to the neighboring tooth. The other thing I would be mindful of is not so much just the space between the coping and the tooth, but more so as I go to remove the impression later on, what path of removal am I going to consider? Because it is more so the accuracy of the impression coping being within the material. And even though maybe only across one plane the material may be thin, the dimensional accuracy is only going to be more in jeopardy from movement. So if you are sort of want that extra level of confidence of the accuracy of this impression that you're about to take, and I assume it is for a single tooth implant site, another thing you can consider is that you could use your flowable resin or blue resin, blocker resin. I would tie a knot of with a floss to the coping and bring it across to an area that is not in an undercut, typically on the labial aspect or the incisal corner of the adjacent tooth. And I would link some resin along there and to have a little island bubble onto the next tooth. Snip the floss off, and then I would go through my impression taking as per normal. But then on the removal, as I inspect the internal area of the impression, I should not see any rotation of this little resin island that forms part of the shape of the tooth next door, just to ensure that there has been no movement during the removal of the impression, if the area is so thin. But preferably, as I mentioned before, I'd rather shape my impression coping to not feel too close to it. But at the same time, you must ensure the features to lock into the impression material remains. Yeah.
I've done in cases where, like in the case you described, is due to angulation of the implant, so it's tipping against the tooth in the mesial. Then you shift the impression coping all the way back, and you just get a floss contact through.
Barely through.
But you've trimmed all the impression coping already. I mean, I've never trimmed the guide pin, but
I have.
You have. So, but what I do is a floss through is not going to be sufficient for your ceramics to make a nice contact.
No.
So you're expected to adjust the contact a little bit more. So ideally more than 0.5. That's I think PVS in between.
Right.
They can still clear that and then make a good contact. But anything under, I think you are expected to trim the ceramic more. Yeah.
Do you think in these cases that digital impressions could be better?
Yes. But
Yes
would the
and
skin
no.
body be? Yeah.
I think with yes and no. The reason why I say it is if it all works through the digital workflow, then yes. But the trouble with digital workflow is that sometimes when you have those cases where the crown comes back and there's a bit of open proximal contact or the occlusion is not quite right, it is then very difficult to troubleshoot where along the way did the error occur. And so those who have embarked on the digital workflow will have this experience that I just mentioned, and it takes a little learning curve. So yes, it would have that advantage if you have mastered the digital workflow, but no, not necessarily if you are still developing. Yes.
This particular viewer is asking in regards to digital impression technique, and also on top of that, milling my own implant crown. Haha. So if it doesn't fit, well, I can always slap on a little bit of feldspathic porcelain myself, right? Something for us to consider.
Yes.
What do you use to block out your undercuts?
I use just orthodontic wax to block out the undercut. It's a cost-effective solution.
Absolutely.
But make sure dry the teeth first and then.
Yes, orthodontic wax and a little bit of saliva to push it in.
Yeah, to contour.
And when do you consider using a close tray technique?
Basically, when the mouth opening is quite limited, for example, S7. Yeah.
Yeah, so we definitely find that open tray is a lot more predictable. It's actually more accurate than a closed tray. So a closed tray is a last resort. As in, if you, for whatever reason you just can't do an open tray, then you just have to do a closed tray.
But I do find the closed tray usually is your finger tightening or with an orthodontic plier tightening, and that becomes a little bit challenging itself. Yeah.
There's some systems that actually have a screw thread which for you to tighten the back.
Yes.
But whether the patient can open enough,
Open enough,
get a
yes.
driver in there, that's another story.
True.
And what about for multi? Let's have a look at this case here of Alice Johnson, where it's a multi-unit case, where we have designed to construct a one-piece bridge. Some clinicians have the view that that you just put in the impression copings and you just take an impression as per normal open tray. Some says you must splint. What are your view on that?
You must splint because any movement, because even just when they're pouring the plaster, any 1% movement will just ensure your implant bridge doesn't fit anymore. And then basically they either have to section, resolder, or they just have to redo an implant bridge for you. So you must splint the implant impression copings, otherwise you are liable for more extra vet fees.
Absolutely.
Yeah.
So basically, what happens when your bridge doesn't fit?
Yes.
Who pays for that then?
Yes. You may either stretch the relationship or increase lab feel.
And in terms of splinting, how are you splinting it? If this is your technique, could you explain to a viewer what are we seeing here, and what are the materials that you're using?
So my splinting has changed over the years. When I first splinted implants, I think it was 3 years, 3 years after graduation of it. Yeah, about 19 years ago, I used to tie the floss and then using a self-cure resin.
Yes.
But basically, that in itself, there's so much shrinkage that is inaccurate. They basically send it to the lab and then they section it again for you to come back and then you link more resin into it.
Sure.
And I went through take initial implant impression, get my lab to cast some wire.
Yes.
And then you split that
to the
finger of eight.
Types,
about the similar size wire as what we are using now. And nowadays I find this technique is quite predictable. So we use the similar casting wire, same thickness concept, and we use a light cure resin that is a little bit faster.
Yes.
We would split in the buccal first, one implant at a time. And then
What's the gauge or diameter of the wire? 3 millimeters.
3 millimeters thickness. So the material that we're using here is by Dentsply. It's a triad. It's called triad gel. It's essentially a light cured resin. They come in different colors. We just chose pink for some reason that I can't quite remember. But essentially, as you can see on the screen, that we apply this material on the buccal then on the palatal for each impression coping, and then this material is also added to the mesial and the distal for each. Now, but what's important to note is that these materials around each of the impression materials does not touch each other. So for example, the 1-3 impression, the impression coping around the 1-3 site does not touch, not the impression coping, beg your pardon, the splinting material, the tri-gel of the 1-3 site does not touch the site 1-2. And so is for the 2-2 site does not touch the 2-3. The reason why you don't want like your resin to touch in between them is because, well, resin, as all resins do, they shrink, and we don't want the shrinkage is to be towards each other. You want the shrinkage to be towards the buccal aspects, as in pulling the wire towards you, or palatally pulling that wire towards you. So that's a very predictable way and accurate way of splinting the whole thing into one piece. Then using conventional open tray technique, and you just pick the whole thing up. So with this way, when you tighten in your implant replicas, nothing is moving. The whole thing is absolutely in one piece, one rock solid piece. So so we know that when you pour up the master cast using this particular technique, the master cast is an absolute replicate of what is inside the mouth. So using this approach, where back in the days when I had a lot more time, I used to make my own master cast. And so my rule was, if the implant prosthesis that the ceramist make fits my master cast but doesn't fit the mouth, I will foot the bill, because I took 100% responsibility on the repression and the cast manufacturing stage. But if it doesn't fit the cast, well, you better do it again until it fits. Whereas these days we don't really have the time to pour out the cast anymore. So, but our this is the impression technique that we're using for a long time now. So far none of the bridges never have not fitted. So I think it's a good analog way of taking impression.
I agree. I think it's have the same accuracy as casting a figure of 8 wires. Yeah. And then this, of course, is the outcome for that particular case. So beautiful looking work. There is one question while we talk about implant bridges. Is it always necessary for the access holes to be in the center for splintered implants for a bridge? E.g., for a 3-unit bridge, can one of the abutments afford to have some cantilever? It's almost like saying, I guess for a 3-unit bridge, you got 2 implants. Yep.
The 2 implants, in a way, it's saying that it's not placed in the ideal, perfect ideal position, where there is some sort of positioning issues, resulting in that there's some sort of cantilever effect of one of the pontics. And the access holes are not coming out of the ideal mid-cingulum or the mid-occlusal of the 2. So let's maybe stretch this further. What if you got a 3-unit case and you got 2 implants on the distal? Can you make a 3-unit mesocantilever bridge? In a way, that's even more cantilever effect than, I guess, what this question is about. So 1, I think it's mechanically, can you cantilever things? 2, does the screw hole, access hole, absolutely needs to be in the center of each tooth position? Any thoughts on that?
So mesial cantilever definitely, provided you ensure that the occlusion is light on the mesial cantilever. Regarding the screw hole in the middle, I mean, it's ideal to design your prosthesis from a hygienic point of view, in terms of you don't have overhangs. But in terms of if the screw hole is in the middle, you can have porcelain on either side. But if you don't have it, then it's better. You can still have it, but you increase your metal support or your monolithic material support. So I think
there's just a lot of hypothesis around this question. I think, even from the foundation up, you have to think about where these two implants are emerging, and whether your 3-unit bridge, as an example here given, are you talking about just a tooth color 3-unit bridge, or are you talking about more like a prosthesis that replaces pink and white? So, because that is critical of where that emergence is and whether that emergence is in view. So there are some aesthetic and hygienic elements in this emergence, as per what Johnson's just covered. From a mechanical perspective, it's no different in assessing whether it is a true cantilever situation, talking about one single implant perhaps in the canine, bearing a lateral incisor, for example. Of course, then those actual physics or mechanic principle will still apply. So, and it's interesting how this question relates to load, because the access is not often exactly just about where the implant would be loaded per se. These days we have like angulation changes that later on we will talk about briefly, in order to design a prosthesis where it could have a balance between aesthetics and the supporting of the ceramic material. So there are so many things to consider. But I hope that the way we try to cover all these aspects, it's helpful to the specific person who has asked this question. But yeah.
I think it's talking about the access hole. So from my point of view, I think as long as your implant design meets mechanical, of sound mechanical loading philosophies, it's hygienic to clean, it's aesthetically pleasing. In a way, and of course, where the hole's coming out, it's not detrimental to the structural integrity of your implant prosthesis. It doesn't really matter where the access holes are, whether it's right in the center or it's coming a little bit more mesial, a little bit more distal. It probably doesn't matter so much. But of course, it's coming out of the mid buccal of that implant in the central incisor. Well, that's not very sound, of course.
It's just the customized ceramic plug, right?
And okay, so now that we got an excellent impression, let's move on to design. Some of the questions here are about how to design implants. So we know that there are cement retained prostheses and there are screw retained prostheses. Agnes, any thoughts on what is your recommended prosthesis design of choice?
I mean, between screw retain and cement retain, I much prefer screw retain because of the ease and the true properties of being able to be retrievable and surfaceable. Many will argue that cement on can still be retrievable. Just like how you would retrieve a cement on crown on teeth, you can cut it off. There has been different expression of mixing temporary cement with Vaseline, for example, to supposedly make it retrievable. But it is not always so straightforward. And of course, there are other technique sensitivity issue to deal with delivering a cement on implant crown, where you have to deal with any potential issues or soft tissue issues with excess cement or the gap that is possible with the cement layer. So personally, I really still do much favor screw retain. And as we can see, that another main advantage that people seem to claim on a cement on crown is the fact that the implant therefore can be placed coming through the incisor edge, typically of a anterior incisor, and therefore it could be loaded more towards the axial of the implant. Subtlety, and there are so many myriads of different situations that you can think of mechanically. But these days, if we go on to the next slide, we can actually see that screw retained prostheses have also come a long way. So traditionally we began with having straight access, full access, and we try to deliver this by perhaps uprighting the implant placement a little, ensuring that we get this access through to our palatal or in the center of the occlusal of a posterior tooth. But more and more now, we know that, moving on from that, we can have up to about 10 degree of angulation offset to this traditional method. It could be delivered in a 2-piece extraorally cemented method, but 1-piece delivery to allow for that 10 degree change. And if we could not achieve it traditionally, we can then look at a cross pin or a transverse type of screw as a prosthetic screw to help deliver these different scenarios. But nowadays, we have further angulated choices, and that includes either a complete change in, for example, having an angulated screw channel within the implant, like the coaxial system, or we could still have a traditional system where the flexibility of the change in angulation comes from your driver delivery to the screw, such as the dynamic system. So we have many availability these days to overcome an angulation issue and yet still deliver a screw retained prosthesis, and that would still be my preference, just because of the ease in future maintenance and access.
One question from the audience asks, well, how do you then determine what type of implant abutment would you choose, straight or angled? This is assuming that the implant is placed elsewhere. It's now referred to the practice to restore the implant. I assume it's not in the ideal position, being in an anterior. Any help, any tips on that?
I think the choice of abutment is not just limited to the angulation, the depth of where it emerged, the actual placement in 3 dimensions, vertically, angulation-wise, horizontally, all plays an impact. So commonly, if I receive a case where the implant has already been placed, and then we had to, in retrospect, think about how now we are able to deliver a prosthesis. I will start from envisioning where this the crown prosthesis would be in terms of profile and form, and then how this tooth relate to where the implant platform emerge. And then according to the anticipated abutment color, design, and emergence, as well as whereabouts, how much degree of angulation change I'm anticipating. With all of those things considered, then I will try still. My preference is having a 1-piece delivery wherever possible. And when that is not possible, that is when I would consider, is there another 2-piece solution to this case, that I will still strive very much on that retrievability in that 2-piece scenario. And sometimes we do have to think a little bit outside the box. But those will be my steps in the planning process.
My advice to that question will be, well, first you got to figure out, do you want to have a screw retained prosthesis or a cement retained prosthesis? Assuming that you're okay with the cement retained prosthesis, then it really doesn't matter what abutment that you're going to choose. But if you want to have a screw retained prosthesis, then often your choices might be, then it's very easy to figure that out. Because then it depends on how bad that implant angulation is for you to correct. If it's anything less than 25 degrees, usually you can use an angulated screw channel type of abutment. If it's greater than 25 degrees, that means crosspin is your only other solution. So here's a very interesting question, something I've also never thought about. Would an angulated abutment screw, so we're talking about your ASC type of abutment screws, be screwed to the recommended torque, or so when you deliver to 35, would the abutment screw receive 35 Newton-centimeters, or would it be a vector value due to it being not parallel to its long axis? Never thought about that before. according to, say, for example, normal Biocare, they just say, well, our ASC's abutment screws, you deliver the 35. I just sort of assumed that preload is up to 35 Newton centimeters. Any thoughts on that? Any mechanical experts?
Yeah, so it's an interesting question. I've had this discussion with a colleague, of ours. So two prosthodontists talking whether it is feasible or not.
Sounds like a great Friday night topic.
Well, we were just trying to figure out whether that would actually be better or a coaxial system where actually the design is within the implant, although it does leave segment of the implant in cross section rather thin. But in the end of the day, so far there hasn't been even a lab study which I am intrigued. But I do feel that it is very technique sensitive enough in a straight line access delivery for people to apply their driver and torque to 35 without stripping the screw. Many of us can do it, but we have to say that sometimes we still see stripped screws.
Yes.
So, and that's in a straight line access. So in the end of the day, I do feel that, in the ASC situation, you have more technique sensitivity in ensuring that engagement of the driver to the screw head. Provided that you have that engagement firm and you torque, and you're able to torque to 35 without stripping the screw, then I would think in theory, then the screw preload should be at 35. But if you actually, slip in any way, or you feel that that delivery is not exactly to 35, then it would already have slipped beyond that. But I think it's definitely worth a PhD, or certainly worth any university colleague, faculty colleague, please do a laboratory study.
No, it's a great study. I'll certainly ask the manufacturer.
Yes, Ben, become
for you. No, but
your next PhD project.
My gut feeling would think that given it is delivered at a vector, the true preload probably will be a little bit less than 35.
Yeah.
That would be my gut feel, but I'm not sure. This is a great question. All right, so now that we've covered, thank you, Agnes. Now we've covered quite a few screw retained options. So this is, I break it down in clinically. This is what the option that we're referring to, which is angular screw channel, meaning that your abutment is a special type of abutment screw. Of course, a special type of driver, where the driver does not need to engage the screw from head-on, so to speak. You can change it up to 25-degree angles, and so therefore your implant placement could be, for an anterior, it could be up to the buccal incisal third, and yet you can then bend that screw channel back to the mid-cingulum. So, for example, this particular case here, you can see that the implant placed coming out of the incisal edge, because this is from a biological standpoint the ideal bone volume, and also from a soft tissue standpoint gives you the best of buccal soft tissue aesthetics. So traditionally we might have to do a cross pit in a case like this, whereas now using these angulated screw channel designs, your final screw channel is in the mid-cingulum. And yet still satisfy a one-piece prosthesis to give us not only an ideal tooth color aesthetics, but also a great soft tissue outcome. In terms of designing the restorative emergence profile, Johnson, what are your thoughts on that? What is it that you're looking for, or you're guiding our ceramists to give you that profile?
Yep.
And or maybe what not to do?
What not to do, yeah. So it's like from your root to the CEJ, basically the tooth should be flared. So same as your implant profile, it should be flared to support your gum, your emergence profile. And the way to do this, when I issue the prosthesis, not over 99% of the patients does not have to be numbed. So you will know, you'll say to the patient, when I remove the healing abutment, there's going to be a bit of pinch. But if the patient jump, like you punching them in the face, then they need to receive some injection. But usually with your previous experience, you know. And once you insert the implant, what you want to see, there will be some blanching. And when you tighten over a period of 5 to 10 minutes, they'll feel a little bit of a pinch, but the blanching improves and they're not painful, and then you just tighten again. And in a way, having that flaring would be the best for oral hygiene and also having a nice emergence profile. But what you don't want is to have it straight, of what we call a mushroom-like. So in that way, when you insert this prosthesis, there will be no pain. You can insert it within 30 seconds. And basically the gum will drop by about 1 millimeter. So that may reveal your monolithic, very opaque white zirconia or your metal. But this is not good for oral hygiene, and also doesn't look good aesthetically. So this is what you don't want, because you get a lot of undercut for this kind of cases. And also what you don't want is to overflare in, next slide, in subcrestal cases where you want it to be straight and then flaring. So what you need to tell your technician to do is to no flaring or straight in the first 5-6 millimeters or in that description. So in this case, the radiograph on the left, where the ceramic is hitting the bone, preventing the seating rather than the contact, then I have to adjust the ceramic and the metal part to get the implant seated.
Great. So in the under contoured situation, which is the one that we saw that almost looked like a mushroom, I guess the rationale from the ceramist point of view, as in why would you want to make something that's in a mushroom, is that they probably learned that if they made a more gradual emergence profile, when they give that to their customers, which is us, the restorative dentists, when we tighten that down the patient, it hurts the patient.
Correct.
So they probably thought, okay, well, it's probably a good idea so that you have an under contour prosthesis. So when you tighten it down, you tend to hurt the patient less. And that was more of an encouragement. So, but I guess that the problem, as you alluded to, is that there's increase in risk in plaque and adhesion, and just basically it's a ridge lap, and that's just can't be a hygienic concept. And then now, in terms of perhaps over contouring your restoration, how do you then get that information to the ceramists? How do you tell them, what is overflared? How overflared is overflared? What do you write in that lab sheet for them?
So basically, it's always good for any technicians that you haven't worked with a long time to give them the X-ray as well, and then you can mark on the X-ray and then say how millimeter should stay straight. Right.
Before that
flare.
That's a great advice.
While we're still on this topic of the screw versus semi-retained, and to provide our audience with some answers, with the angulated screw channel, there is actually been an in vitro study to look particularly at this preload, the ultimate preload to the screw. And what they have actually found is that up to 15-degree correction, there's actually no significant change to the ultimate preload. However, beyond that, between 15 to 25, there is a gradual decrease of this preload transfer to the connection. And certainly, this is significantly not advocated between 25 to 28 degree changes. So I suppose in this circumstance, you have to balance it with the parafunctional risk of the patients, the potential maintenance. But certainly, I think still having that retrievability, and I'd much rather a loosened screw in this situation than other things breaking. Because it just depends where's the weakest link as well, isn't it? But I hope that information has been helpful and a bit more numerically specific and relevant to our audience who asked that question.
Now, once the prosthesis is properly designed and we're ready to insert that screw retained prosthesis, Agnes, any advice on how to go about checking it before you deliver that process intraorally?
So I would ensure that the proximal contact we spoke about, it shouldn't be too tight. So what shouldn't be too tight is that when I check on the model and also in the mouth, I would commonly like it to have at least 40 micrometer freedom, and that's typically your blue articulating paper, the thin blue articulating paper. It should pull through without ripping. And other way is to be able to floss through comfortably.
I really do like that flossing test, if it particularly if it's from a good lab and you know they haven't damaged the model, and once you've tightened, you floss that down. If that feels good on the model, it's probably going to feel really good inside the mouth. But if that's extremely tight on the model, then chances are, well, that's not going to sit all the way down inside the mouth either. So once you've checked the interdental contacts, then I guess the next is inserting the prosthesis. Many clinicians probably don't take a PA once you finger tighten. They just tighten and then crank it down. Again, just like I guess that the impression PA that you were talking about earlier, it's just good practice to take a PA. So that's certainly what we recommend too. So that once you hand tighten it down to a snap fit, and then you just take a PA, what you want to see is not what the clinical PA that you see on the left is. In fact, it's the one on the right. You want to see something like that before you would use your torque wrench to tighten down, because if it is in the left instance and you just decide to torque it down, well, there's definitely got to be some sort of mechanical stripping between your abutment to the implant, which is not good. So once you delivered the prosthesis into 35 degrees, or any of your manufacturer indicated torque value of choice, then you would have to seal your access hole somehow. Any particular materials that you like to use, Johnson?
I like to use PDFE because basically when you try to, it's easy to pack, and then you can just make even if the depth is high, you can just make a long string and then you just pack it into the access hole. The main thing is we do a routine check on the screw tension regularly. So main thing is unlike cotton wool where you hit it, it just goes spun around the This one doesn't. It's just a very dull feeling. You can just keep on drilling and remove the composite. Very easy to place and very easy to remove as well. And how far do you pack it quite firmly, or is it a loose sort of packing? No, you have to pack it quite firmly. So because you still have to put a composite on top. And regarding the depth of composite, that depends on how much undercut your technician provided you, but generally we want to have a composite of 2 to 3 millimeter. That's you can just cure in one setting. That's the curing depth.
And do you have to etch the ceramic?
I used to when I first started, but then when you spend a lot of time etching, putting grooves in, putting different colors in, you are unlikely to remove it again. Nowadays, just opaque composite, no etching, because there's undercut just to pack it in.
So it's just a occlusal seal. It's a lid, really. Now, once the implant is in, the prosthesis is in, and then we've got to talk about long-term maintenance. Agnes, any particular studies on, is there a recommended protocol on how often should we recall the patients back, and what do we do when we get these patients back?
So this one, I actually did a recent look in the literature, and I can confirm that this is for real. There is actually no literature out there on maintenance protocol in terms of prosthetic. Even in the periodontal
implants,
implant prosthetics.
Not for the prosthetics.
Not for implant prosthetics, not for removable implant prosthetic, not for fixed implant prosthetics. Even in the dental implants from a periodontal standpoint, and for both biological and mechanical, there's been a lot of data on survival rates, complication data, risk factors, what to do, how to manage the complications, but not actual recommended maintenance protocol. And it's an interesting summary from periodontal literature in terms of looking at peri-mucositis, peri-implantitis, is that the concluding remark is they would recommend early detection of any signs of inflammation before it becoming infection. And I thought that was very wise. And if I may borrow the current periodontal commentary on soft tissue, I would share that my feel for the maintenance for mechanical issues is that you should do early detections before any catastrophic prosthetic failure occur. And I think, Ben, at this point, you're going to share with us some of the maintenance review checkpoints that we routinely cover, so as to make things more serviceable and maintainable, and less likely to result in catastrophic failure.
Sure. So this is the maintenance protocol that I've been using at our practice. And the theory goes that this is, of course, under the understanding that the patient is periodontal disease free, they have reasonable oral hygiene, and they're doing all the right things, is that we will see them the first time for the first review 1 year after prosthesis issue. In the first year, what we're looking at is, of course, periodontally. You can use metal or plastic probes, and resin probes, and the picture that you saw on the screen before with the one that's yellow one, that's from Hugh Friddy. These are quite flexible. So, and the benefits, one is that the marking is very obvious, so you can see the periodontal probing depth much easier. Secondly, it tends to hurt the patient a lot less, given that it's somewhat flexible. In terms of oral hygiene, I'm a big fan of pixters, or especially for interdental brushing, cleaning. Of course, I have nothing against flossing, but often, particularly for the posterior aspects where there is papilla loss around implant prosthesis, I do find that pixters are a lot more easier, probably more effective too, I think, than a conventional floss. The other thing that I'm a big advocate for is water irrigation devices. There's a large number of them out there. This one is a water pick from this is a water flosser from Waterpick. The fact that I quite like about it is this particular unit is it's got a power dial, on the corner you can see. So once you crank it up to a higher setting, it is actually quite a forceful unit to help you to debride subgingivally, to wash out all that sort of stuff. Once when the patient comes, if there are any tartar, any calculus, and you need to debride, you could also use these resin manual curettes, or you can use these soft tips that you put over your cavitron, which are for obviously your subgingival debridement. I think if an implant prosthesis is well made and designed using a good material, i.e. whether it's zirconia, whether it's titanium, something along those lines, and it's well polished, usually calculus is very easy to come off. If you're having trouble, I think, removing calculus from implant prosthesis, then there's something really not quite right with that prosthesis. Something that isn't done, I think, I haven't read anything in the literature about it, but something that I'm a big advocate for is checking the implant occlusion, because implants, unlike teeth, that they may look and feel somewhat like teeth, but mechanically they don't behave like teeth. Teeth have periodontal ligaments, so when you bite on teeth vertically, there is up to 100 microns of vertical displacement in physiologically healthy teeth. However, with implants, you're lucky if you get 10 microns. So that just means that your implant is it's more likely to become overloaded when compared to teeth, and that's why the test that we use is shim stock clearance. So in this photo here, what you're seeing is that the tooth number 11, it's a tooth-borne crown, and tooth 21, it's an implant supported crown. So this is after annual check. So what you see is that the shim stock on the left is tight because that's biting against teeth, but it is not tight on the on the implant. So you want shim stock clearance in centric, and ideally you want to minimize any contacts during lateral excursion or protrusion. Sometimes you don't have a choice, that there's even even contacts during protrusion or group function during lateral excursion. For aesthetic purposes, you just simply cannot make one central so much shorter than the other. So hence group function, it's unavoidable, but otherwise, at least in central or heavy bite, you certainly want to reduce that contact as much as possible. Radiographs, I'm also a big advocate of using these holders, because it just helps you to consistently taking more parallel PAs, so it's easy for you to check your crestal bone level that's in a comparable manner year after year. And the other thing that I do is I want to check the abutment screw tightness at 1 year level. Because what I'm looking for is, let's say the abutment screw tightness did not change at all at a 1 year level. And that's a really good thing. And that suggests to me that perhaps the patient's occlusion is controlled, there's insignificant parafunction, and we're doing everything right. That's terrific. So then if everything looks good, then we're going to seal everything up. Then I might see the patient in 2 years' time. But if the abutment screw, for whatever reason, it was somewhat loose and I can actually tighten it to a certain degree, then I'm going to then look into the occlusion. Could there be parafunction and all those sort of factors? Because chances are there could be. And if there is any soft tissue, that's an unideal soft tissue presentation, whether it's somewhat bleeding on probing, or there's a little bit of creamy discharge on probing, then I probably do want to obviously improve on the hygiene and see the patient probably yearly until I'm not seeing these risk factors, and take it from there. We're somewhat coming up to the evening, to the conclusion of our evening. Once again, just to remind all the viewers home, if you haven't done so already, to receive your CPD certificate, please do scroll to the screen below and fill out that section. And before we take a break for the rest of the year, any closing remarks, Agnes?
Yeah, I think in extension from what your last comment is in terms of the maintenance of the occlusal scheme, and I think there was a former question about how we should design occlusion. Is it little contact or no contact? I think the remark I have is the shim stock clearance is a recommendation, and it comes from the fact that the implant has no suspension like your periodontal ligament. So while this shim stock clearance is recommended for most, I think it is very important as an individual, as you check, I often will go for the maximum clench from the patient, because everyone's periodontal movement of their individual teeth and occlusion are somewhat different, or even just how much their jaw depresses as they clench. So when we do the maintenance, aside from checking the load, the checking of the occlusal scheme, I feel, is of particular importance, especially the fact that, like Ben had said already, the ceramic is not only color stable, it is also much more resistant to wear. But natural wear and tear occurs on our teeth, of course, from parafunction, but erosion and other aspects are also quite prevalent. So, when I go for my routine check, I always will check this occlusal scheme, not just as a finishing and delivery technique, but it is something that you have to maintain ongoingly for the health of that implant. So I definitely would try to have a bring home message is whatever you're doing, whether it's a single tooth implant or implant bridge or implant retain prosthesis, whatever occlusal scheme you're actually delivering, that is part of the maintenance check, that the occlusal scheme would remain, and you do things that will keep that maintenance also. So yeah.
Beautiful message. How about you, Johnson?
Management of pair function is very important, whether it's nighttime or daytime. Like the electrician case I was talking about, 10 micron is certainly not enough because it can clench so hard. But also getting a good ceramics, having the good framework design that will reduce porcelain chipping, good technician that will make sure don't break your model. So you have to adjust the contact, or it's not sitting, so you're not delivering the proper amount of torque, so to increase your early abutment screw loosening. So those are my take-home messages. Yeah. How about you, Ben?
Well, here's a question which is sort of somewhat focusing on what I was about to say, is that this is a very unfortunate situation from one of the viewers, where it was a periodontist that placed an implant for this dentist patient. Unfortunately, the implant was quite lingually tilted, and so once the crown was restored for this molar, there is repeated abutment screw loosening because, I guess, of the non-angular force that is received. It's a 2/6, sorry, by the way. After a couple of times, the patient had to retighten, the screws quite a few times, and obviously the patient is not very happy. And what should I do? So it's never easy when something like that. It doesn't matter, I guess, how you change the angulation of that the abutment screw. The ultimate load on that tooth is exactly the same. So, but one thing that pops in mind is perhaps to change the shape of the molar. So instead of having from the buccal-palatal dimension of a normal molar width, reduce it to maximum premolar. So in other words, you're not mesiodistally, it still looks like a molar, but buccal-palatally, it's a very skinny molar. So what you're doing is that you're reducing the occlusal table. And it's when you reduce the occlusal table, now you're reducing your so-called your pounds per square inch. So and hopefully that that reduces the less stress on the abutments on the abutment screw. In addition, it does make a difference on how wide that implant is, which means how wide your abutment screw is going to be. And if it's chosen that's quite skinny, then that's another problem. So my take-home message is, in fact, failing to plan is planning to fail. It doesn't matter how much experience that you have. We all have to have our checklist at our practice. You just have to methodically work through every single step of your plan. In this particular case, if you're working with a surgeon, maybe provide him or her with a surgical guide if this person is not very angulation, sometimes could be an issue here. Maybe give them some sort of guide, and hopefully they use it, or force them to use it. Otherwise, threaten you're never going to refer to them ever again. Something along those lines. But obviously you are working in a team, and that has to be.
And I think together. for the colleague with our last question, if the implant platform is already quite palatally placed, and you feel that it's very difficult to deliver a narrow occlusal table, there are often ways, like, think outside the box. Maybe that Emergence could still have a carabellar cusp that doesn't become part of the occlusal table, and you still may be able to still have a reduced occlusal table of where it functions. And what's more is that you now know that with that angulation change, perhaps it is going to be more occlusally challenged, and therefore balancing the aesthetic appearance, maybe you do have to have it a little bit less away from the maximum clenching and grind type of action, to be like a lot more disclosing on those factors, wearing a splint, etc., that you can talk the patient through. So hopefully that helps you, and if you need to, you can further PM us separately if you need some more assistance on the case.
Absolutely. There are a couple of questions throughout the evening that I didn't refer to the panel because the questions were sort of outside the scope of the topics that we wanted to discuss tonight, because we want to stay focused, and we still ran over time, and Brett is now giving me death stares. So before I get into too much more trouble, I do want to wrap it up. I want to thank you, of course, the viewers that's been joining us. We always have fun in these sessions. I want to thank our referring dentists for the year. This is our last webinar for the year. Of course, we will return again in February next year, and we'll keep you close updated on what that program would be. I would like to thank my colleagues once again, Johnson and Agnes, for joining me this year. Thank you so much for your time and your tireless energy sharing.
No, thank you, Ben.
Thank you, everyone. Thank you, Agnes. Thank you, everyone.
Thank you,
also,
Johnson.
A big thanks to our sponsors. Without them, we simply cease to exist. We want to thank Brett, who's always working behind the scene. We wish you can see his setup.
He was actually our literature delivery segment. We can thank him about the ASC.
Yes, don't forget to fill in that CPD portal for the rest of the evening. So, thank you once again, ladies and gentlemen. Have a wonderful evening. Have a safe and merry Christmas, safe holiday seasons. Bye for now.